our guest speaker. We're going to be going over psychiatry with a psychiatrist. So yeah, just thank you guys for being here. And don't forget to sign in. So just a little bit over our membership requirements. We have active and alternative. So same things if you've been in here at the previous meetings. Attend 3 to 6 general meetings, 2 to 3 events, no requirements for socials. You have to do 10 volunteer credits and pay your dues, 15 or 20, depending if you're a returning member. And then it's pretty much the same thing for alternative membership, but you have to submit proof that you can't attend our meetings due to a schedule conflict to Debbie, our president. You still have to attend 2 to 3 events. Again, if you cannot attend, please send proof to Debbie. No requirements for socials. Complete 15 volunteer credits instead of 10, and then your dues are $5 more expensive. So please, 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 please follow us on social media. That's how we kind of stay updated with y'all, as well as our GroupMe, which is on the QR code right there. Another important one, or the two big ones, are Rowdy Link and YouTube. We post all of our meetings there after the meetings are held, and then the Rowdy Link is how you receive our recap emails at the end of the week. And then our volunteer opportunities are both virtual and in person. So these are a couple of our virtual ones. We have letters of encouragement to the Children's Shelter, San Antonio State Hospital, or through Love for the Elderly. The first two have actual physical addresses that you can send them to. Love for the Elderly, you look through the website and you can see where you can send it there. I can also send it to you. So 1 letter equals 1 credit. We have the UTSA pantry where you donate 6 items and you get 1 credit. They usually give you a slip saying how many you donated. You also take a picture and send it to us. 7 Cups is an app where you basically just chat with people and take a screenshot of the time that you started talking with them and the end. You're basically just providing like free online therapy, just kind of like a friendship sort of thing. So that's 1 hour equals 1 credit. And then you can also just donate money to us. $6 equals 1 credit. Then our in-person volunteering events, it's going to be Satellite Center is our next one on October 30th. And then we have Morgan's Wonderland. That's October 16th and November 6th.
The sign-up sheet will be sent after tonight's meeting. So make sure you look out in the GroupMe for that. Okay, so for our general meetings, we have this one. It counts towards credit, and then we only have 2 more that count for credit. So if you're just starting on your general meeting credits, please make sure that you do sign in and sign out. If you do have technical difficulties, please send us a screenshot or send me a screenshot within the time frame. Otherwise, I won't be able to do anything for you. Let's see.
So our next 2 events are Traveling with Psychology. You basically, we're going to have a couple guest speakers and you can kind of learn how you can use your psychology degree to travel wherever you want to. And then our last event is going to be professional development. So you learn how to write your CV, resume, personal statement, etc. with 3 of our guest speakers. Again, you have to do 2 out of 3 events. So if you haven't attended our last one, make sure to attend these 2.
Also, I see that there's some messages in the group chat. As mentioned, it's 15 volunteer credits if you are an alternative member. If you're a regular member, new or returning, it's 10 volunteer credits. So it's not 5. Okay, so we do have officer positions for the spring 2022 semester. I did have a few people asking me already, so these are the positions available. We have public relations, we have volunteer coordinator, so we have 2 positions open for that one. And then we have fundraising chair. Fundraising chair is a position that we used to have in the previous semesters, and we decided to bring it back for next semester. If you want to know a little bit about the positions or want the application, send me a message and I will send that to you. I, however, will not send the applications until October 26th. Okay, so important dates, October 26th, membership dues are due. If you do have financial difficulties, you need to send me a message ASAP. Otherwise, I can't really do much for you if you send me messages at the last minute. And then that's when officer applications open as well. Then November 9th, that's when all requirements are due, and then officer applications close. Obviously, you know, it's important for you to complete requirements if you want to apply for an officer position. And we are doing Best Fest this Friday. So I did get a few people asking me about volunteering for Best Fest. We are also sending out the sign up sheet tonight after the meeting, and we are going to limit it to 1 to 2 members per shift. When we're starting the shifts from 4 p.m. to 11 p.m., which is when we have to close down. If you want more information, you can send me a message. And I will try to stay a little late tonight if you want to talk to me about any specific questions that you may have.
All right, so please buy merchandise. If you saw us at tabling, we kind of had it out there, but it's gonna be $15 for tumblers, $20 for thermal mugs, and $15 for water bottles. And that's what they look like. And then we have our double-sided mask and our t-shirts as well. Then this is how you pay for the merchandise, as well as send your dues or give us donations. Any kind of payment is going to go through here, or I can arrange a meeting time with you to get the cash, but this is our preferred method of payment. And make sure to use the correct code. So like if you're buying a mask, use the code M, and the t-shirts, as you saw on the slides, they have their own code as well. So get right into our topic of psychiatry. We're going to be presenting Dr. Tracy Schillerstrom. I hope I said that right. We really appreciate you being here, and I'll just let you get to it.
Great. Well, thank you. Appreciate the invitation to speak to your organization tonight. I don't have anything formal planned. I was thinking that I would just sort of march you through some of my experiences and kind of my journey through psychiatry. And then, you know, that can open up conversation for comparing psychology to psychiatry, or what does medical school look like if you're majoring in psychology. But really just any questions that you may want to have a chance to explore a little bit further is my hope for tonight. I'll tell you just a little bit about myself. I'm actually the psychiatrist at UTSA. So psychiatry has the Student Counseling Center contracts with UT Health San Antonio psychiatrists to provide psychiatry services for UTSA students. So I've actually been out there since 2012. And the way that I'm out there is as a supervising psychiatrist for our psychiatry residents. And so I can talk a little bit about what that means, psychiatry residency. But anyway, I just think that, you know, UTSA is just doing such an amazing job of just supporting students towards their goals of graduation. And so I'm really happy to be here tonight and you know, help y'all explore some possible opportunities beyond college. So so if y'all have any questions, please interrupt me. Otherwise, I'll just kind of ramble. So if you have anything that you want to ask, I'm sort of okay with checking into chats, but if I miss a chat, I'm not trying to blow you off. Just let me know what I need to talk about. So anyway, my name is Tracy Schillerstrom. I'm super homegrown to San Antonio. So I was born and raised here in San Antonio, graduated from Clark High School. I went to UT Austin for undergrad, and then I came back to San Antonio for medical school. During medical school, you kind of make your decisions about what sort of physician you want to be, and then you apply to residency. And so during that time, I decided that psychiatry suited me best. And so I applied to a psychiatry residency. And from there, I did my adult psychiatry residency. And then you can kind of pick a path and do a specialty in that field if you want. And so I did a 2-year psychiatry, child psychiatry fellowship. And so 2 extra years of child training. And so, so I'm a child psychiatrist. And then when you graduate, then you can kind of do all kinds of things. So you can kind of pick the field that you, or the area that you want to practice in. And so when I graduated from training, I decided to do private practice. And so 7 years I did private practice psychiatry. And then kind of did that for a little bit and learned the business side of psychiatry and medicine. And then ultimately had an opportunity, actually it was coming to UTSA to do the student health center job that helped kind of open the door for me to come back into academics. And so in 2013, I joined the faculty here at UT Health San Antonio, and I've been on faculty ever since. And so that's kind of like a fast a fast track through my experiences. But so that's what it looks like. So when you graduate college and that you're heading on a path towards medicine, that's sort of the way it goes. So medical school, residency, specialty, and then private practice, or whatever you want to do when you're done. So let me just kind of stop there. And I don't know, do y'all have questions in terms of Student Psychology Association versus psychiatry? I don't know how much y'all have talked about the differences, or I'm not sure, I haven't spoken to your group before about how much of that conversation you have.
So we get a lot of new members, so we haven't really talked about this topic before, but even if we have a lot of new people. I know there's a question right now in the group or in the chat saying, what are common misconceptions about psychiatry?
Okay, and then I see, was psychiatry always something that I wanted to do? So common misperceptions about psychiatry, I guess there's a lot. I think there's stigma in mental health care for sure, that we are trying very hard to address and try to normalize mental health, just like medical and physical health. But we still have a lot of work to go. And so I think that stigma in mental health is an issue that is a problem. So misperception of psychiatry in general, or mental health in general, is something that we face as psychiatrists every day. I think that's probably the biggest misperception that impacts our patients and our healthcare delivery. So I would say that's probably the biggest one that is on my mind. I think there's a misperception that psychiatry are just pushing medicine, that we just prescribe medicine to fix all kinds of emotional problems. And one of the greatest joys of my job is when I don't need to prescribe a medicine. And we know that in psychiatry, the ability to prescribe medicine does not mean that that's the right treatment for everybody. And so I think that that's a misperception. I think that any psychiatrist who has been trained properly and paid any attention is going to know that just prescribing medicine and only talking about medicine will not get your patients better, and that we must look at the whole person and the whole situation and the whole dynamic in order to best help our patients. So I think those are probably two big misperceptions that we face in psychiatry. And I think the other question was about if I always knew that this was the field that I wanted to do. No, actually, when I started medical school, I knew for a while that I wanted to go to medical school. That was sort of on my radar through high school. But I think that I envisioned myself either doing pediatrics or family medicine. And so when I was going through medical school, I actually was very close to doing family medicine. And I thought that the joy of family medicine would just be that partnership with families and getting to partner with families and kind of shepherd them through through all their healthcare challenges over the years. And what I found, I thought family medicine is perfect because I like working with adults. I like working with kids. I can, work with families. And ultimately, I learned that psychiatry actually will offer that in the way that I find most rewarding. And so family medicine doctors are blessings and they work so hard and they have to take care of so many patients. And the challenge can then be that they almost don't have enough time to even talk about or address the mental health needs of their patients, even though they are the first line, they are our first line treatment for mental health. But it's like they have so many other things on their plate. So they're talking about diabetes, hypertension, you name it, ingrown toenails, and also depression and anxiety. And so for me personally, I was wanting to work more directly with the emotional stress and strains on families. And so that led me to psychiatry, but then my interest in working with families naturally sort of led me to child psychiatry. And so for child psychiatry, I get to be these kids' primary care doctor all the time. So these kids coming to my clinic with ADHD or depression or anxiety, they are seeing me way more than they're seeing their pediatrician or family doctor because they're coming in and they're checking in every 3 or 4 months. And so my original interest of wanting to work with families and kind of shepherd them through life over time has really come true with just with my job as a child psychiatrist. So I saw, what is a day? Oh my gosh, there's a lot coming in.
I think
Go ahead.
Sorry, I was gonna point out the first question was, what are some things you wish you knew before going into child psychiatry?
I don't know. I kind of feel like I knew what I was getting into. So, before you can be a child psychiatrist, you have to do adult psychiatry first. And so, by the time I had already done 3 years of adult psychiatry after medical school, I had done rotations in child psychiatry. And so, I kind of had an idea of what I was getting into. I think that, the traumas and stressors that kids face, I think I knew about it and I think I was aware of it, but the significance of it and the true impact it has on those kids certainly could not be felt until I was working with them as closely as I was in child psychiatry. So, I didn't fully appreciate or fully see like the great resilience of children. And like I knew it, but I hadn't experienced it until I was working with kids. But that was just confirmed that I had made the right choice. I think I saw kind of a day in the life question. And that's a good question because I think that one of the great things about, in my opinion, one of the great things about psychiatry is there's just so many different paths it can lead you down. So, I started off saying that I'm the UTSA psychiatrist, but I also said I'm a child psychiatrist. And I know you guys aren't kids. So, just to clarify that, my job is an academic job. So I'm an associate professor at UT Health San Antonio. And when you're a professor, you kind of pick, are you on a research track or a clinical track or a teaching track? And so I do clinical care. And so 70% of my job is spent here at Clarity Child Guidance Center, which is a child psychiatry facility for kids ages 3 to 18. And so there's 2 different groups. There's like a Clarity inpatient psychiatry doctor group, and then there's the outpatient group, and UT Health is part of the outpatient team. So kids who don't need to be in the hospital but need to see a psychiatrist on a regular basis, that's the outpatient side of things. And so that's what I do 70% of my time, and then 30% of my time is supervising our residents at UTSA. So I think that that's one of the great things is there's so many different opportunities and things you can do with your time. after your training. And so you can really decide, do I want to be an inpatient psychiatrist? Do I want to be an outpatient psychiatrist? Do I want to practice in a rural community or an urban setting? Do I want to work in this like boutique cash only practice, or do I want to serve the severely mentally ill who are unfunded? Like there's anything and everything. And I think that plus the specialties, in child psych or in psychiatry, you can specialize in different things. So you can be a geriatric psychiatrist, you can be a child psychiatrist, you can be a general adult psychiatrist, you can specialize in substance use, you can do forensics where you're testifying and doing like criminal cases or capacity assessments. What else is there? There's consultation and liaison psychiatry where you are partnering with your medicine colleagues in the hospital to go and see medical or surgical patients who are having a psychiatric concern, and you can consult on them and give your recommendations. So there's just so many different, there's women's health psychiatry. So you can say I'm a psychiatrist, and then you can be in a room full of 50 psychiatrists if you wanted to, and you could just have, everybody would have a different experience, and everybody's perfect job would be different for them. So I think that's the great thing about psychiatry. So my typical day is usually in clinic. So as a professor, I am supervising residents and medical students, but I'm doing it in a clinical setting. So we are seeing patients, and by seeing patients, they are learning how to be psychiatry doctors, and then I'm supervising them. And so it's this neat balance of getting to provide the care that I love to give to patients while training our future doctors and psychiatrists. And so I'm either doing that at Clarity, seeing kids, or I'm at UTSA. And the great thing about at UTSA, it's a great opportunity to speak about collaboration with psychologists and counselors. So we have the student health side, which has, the nurse practitioners and taking care of coughs and colds and all that ails you. And then we have the counseling side. And so, we partner with all the counselors that are at UTSA and get to kind of collaborate with them. So our counselors at UTSA are either, some of them are social workers, some of them are LPCs, some of them are PhDs. So all different levels of counseling degrees. And then psychiatry is sort of embedded within the counseling center. And so we can partner with our counselor colleagues and see students who maybe need a higher level of care, or we need to think about medications that may help their treatment. So that's a long answer, but that's some of the touching on some of the questions y'all had.
The next question that someone had was, what is the hardest part about psychiatry?
I think the hardest part about psychiatry can be, it's the hardest part and it's the greatest part. So, the hardest part can be hearing some of these really tragic things, really, traumas or really significantly hard life events that people have had. And maybe feel like you're not able to help them as much as you would like to. And so I think that can be the hard part for sure. But it's also the blessing, because if someone is brave enough to come and seek out the care that they want and need, and we are able to help in any capacity, then that feels like a really great feeling. And so and I guess to piggyback on that same thought, to hear someone's stress or someone's stressor, or someone's difficult story, if hearing that story and them sharing that story with me helps them, then that's a rewarding feeling for me, even though, man, it can be hard to hear some of those things sometimes. But we're hearing it for a reason. We're hearing it for a purpose, and that's to help them feel better and get better. And so if we're able to take that on and then use that story that they have shared with us to build rapport, build trust, to help them get the treatment that they need, then that's a no-brainer. You know, we will take that stress on every day to help our patients. So I think that can be hard. It can be hard to see patients that you sort of know what might help them. And for one reason or another, they're not able to kind of take those recommendations, and then you see them struggle maybe more than they need to. I think that can be really a hard part of the job.
The next question is, what similarities are there between psychiatry and neuropsychology? What are some differences?
So let's see. So neuropsychology would fall under the psychology umbrella. So psychiatry and psychology, and again, I don't, if I'm oversimplifying, please let me know and I can speed it up. But you know, psychiatry and psychology, the primary difference there is really sort of the path of training. So for psychiatry, like I've shared with my story, that path is through a medical degree. So after college, you're getting a medical degree, you're going to medical school, you're getting your MD, and then you're pursuing a specialty in psychiatry. And with psychology, you are perhaps majoring it in college, and then you're going to get your undergraduate degree and go out and do a job that a psychology degree would lend that expertise to. Or perhaps you're going to continue your education and get your master's degree or your PhD. So in terms of like paths, that's the primary starting point of how things are different. And so for psychology, you're getting your master's degree and then possibly your PhD if you're going to do education beyond undergrad. So neuropsychology would then fall under the specialty track of psychology. So that could be like a master's or a PhD in neuropsychology. And that would look like someone who is perhaps doing a lot of testing, you know, neurocognitive testing, perhaps. That would be sort of their specialty focus with psychology. Versus again, psychiatry, if you kind of just remember that psychiatry is the pathway through medicine, then a psychiatrist is dealing with and the diagnosis and treatment of psychiatric disorders. And that treatment may be through medications or through therapy. And whereas psychology is going to be either focusing on they can specialize in like doing testing and or providing therapy and counseling. And then neuropsychology would be like a specialty within psychology. And they're often looking at, like I said, just cognitive testing, performance testing, looking at IQ, learning disorders, things like that. And then within neuropsychology, there can be a lot of branching out, I imagine, as well with, you know, what population you're working with. You know, are you working with kids and you're looking at like developmental disorders and testing there? Or are you working with stroke patients and looking at kind of post-stroke functioning? But again, it would be more from the behavioral standpoint or the psychological testing standpoint.
The next question was, because you're working with kids, do you ever have parents that don't agree with your diagnosis?
All the time, very often. So the answer is, well, you know, either don't agree or have questions about, but we would want that, right? If they don't understand, if I haven't done my job to explain my thought process well enough, then I want them to disagree and I want them to ask questions so that I can help them understand kind of where I'm coming from and why I'm saying this is what I think is going on with your child. But for sure, there's a lot of times there's disagreement on, especially in child psychiatry, because it can be a bit of a moving target, right? Like kids are Kids are developing, their brains are growing, their lives are changing, their environment is changing, they're changing homes, they're changing schools, they're making friends, losing friends. There's just so many moving parts that that can present differently. And so it may be that they're focusing on one factor, one aspect of the concern for their child, but I'm kind of seeing some other things that I might be picking up on. So they may have come in with one concern and I'm saying, I hear that concern. I think that this other thing may also be going on. And maybe they weren't expecting that, or maybe they didn't want to hear that. So there can be a lot of reasons someone might not agree, but that's part of that relationship that you build with your patients, is to, that's a conversation to have, and that's a door to open to really flesh that out. Maybe I didn't ask the question in the right way, and so I kind of started thinking these other things, and then they can help clarify for me. Or maybe again, maybe that just wasn't what they were expecting. So for sure, people will have different opinions.
I have my own question regarding that. Like, have you ever had a situation where they disagree and they actually don't have your child see you anymore? Like, does that make sense?
Mm-hmm. Yeah. So, there's just a lot of emotion that can go into coming to see the doctor, right? So it takes, there can just be so many reasons why someone may get frustrated with a visit or disagree with a visit, choose not to come back. And again, my hope would be that I can set the stage for a conversation where they can say, hey, I don't like how you said that, or I don't like what you just said, and here's why, so that I can have a chance to try again or do it in a way that is more helpful for them. But sometimes, for one reason or another, people may make the decision that the clinic that I'm in is not the right clinical setting for them, and that they might go and look for care somewhere else. And at that point, it's just my job to try and help that transition go safely, and make sure that they know what their options are, and how to make sure they still have medicine as they make that transition. Never forgetting that they are first and foremost my patients. So this is not a personal vendetta. It's just every patient has the right to seek treatment in the place where they feel the most comfortable. And it's my job to try and make my clinic that setting. But if that's not the case and they want to go somewhere else, then it's also my job to help them get there safely.
The next question is, how do you explain to the kids what they have and need? Like, example, like medicine or their diagnosis.
Yeah, that's a great question. What I like about that question is you are recognizing that if you are a child psychiatrist, the child is your patient. And so the worst thing in the world would be to have a family bring their kid in and the doctor never even talk to the kid, when that's the patient. And so my job is to hear both stories, right? So I need to get the information from the parents and hear what their concerns are. And then I need to get the information from the kid and hear what their concerns are. And then I have to kind of merge the stories and hopefully the stories line up, but a lot of times they do not. And so if you can think about a time in your life where you were a teenager and disagreed with your parents, probably don't have to think that hard, right? Probably 15 things come to mind. But that's what we're kind of sorting out every day. And so we are, if we're doing our job right, we are including the child from the beginning. And so we are talking to the child, we are hearing as much as they're able to share with us about what's going on. We're talking to them and asking questions to best understand, I heard from mom that you think this is a problem. What do you think? You said mom said this, but you don't agree. Tell me about that. And then trying again to kind of merge the stories to form one appropriate diagnosis and one appropriate treatment plan. And then have that conversation with both of them. So, hey, based on what I'm hearing, I think this is what's going on. Here are some of our options. And then depending on the age of the child, they can have more or less say in the decision making. But I'll always talk to the kids like, hey, so I know you didn't hear a word I just said and you're bouncing off the walls. But here's what we're going to do. We're going to start this medicine to help this thing. And you're going to come back and tell me what you think about it. And they'll be like, yeah, whatever. And I'll say, okay, now what did I just say? And then they'll, I try and get them to at least understand the outcome of their visit, because they are the patient, they are the identified patient. And over time, we want to teach our patients to take ownership of their treatment. And that starts from the very beginning with kids.
Yeah, that I guess that's very true. I've never thought about it that like I guess when kids are the patient, at a doctor's office, the doctor doesn't really speak to them, they speak to the parents, and they're sitting right there, and for the most part they can understand, if you say it in a certain way, they'll understand, so
Yeah. But if you think about when you go to the pediatrician, like the parent has a lot of things. They have like a list of things they want to tell the doctor, and they're going to make sure they run through that list. And they're going to get every question answered. And then by the time the list is run, the doctor may think, whew, we did a lot. But they still have to examine the kid. They still have to put the stethoscope to the heart and listen to their lungs. And the same is true for me. I can work my way through mom's list of concerns, and I need to, but I also need to check in with the kid and make sure that we're hearing it correctly from their standpoint, and that we're not missing anything. And that I'm checking in on their emotional well-being. And so that's my job.
The next question was, I'm not sure if this was covered, but how rigorous was grad or med school? As a professor, what do you teach your students?
So medical school is rigorous. I will say that medical school is rigorous. I'm sure grad school is rigorous. But if you are committed to the decision that you're making and it's a path that you're interested in, it's absolutely 100% worth the rigor. So again, for medicine, for medical school, that's after college, you do medical school. So I can kind of give you just a quick overview of what medical school looks like. I can't speak so much to grad school, but I kind of can. So for medical school, again, you've graduated, you have your undergraduate degree. You have to take the MCAT, which is the medical exam, kind of like the GRE for grad school. The MCAT is the entrance exam for medical school. And then you get into medical school, and it used to be your first 2 years were all kind of in class book learning, and then your second 2 years were clinical. Medical schools have come a long way in trying to integrate and get students seeing patients and working with patients and thinking clinically from the beginning. So now there's a lot more team-based learning and synthesized like patient scenarios, observing patient interactions. They do a lot more of that in the early years than they used to do. One, just to keep it interesting, it's really hard to just sit and study all the time. So there are more integrated clinical skills activities that first and second year medical students get to do now. But in general, the first year and a half or so is dedicated to just learning like all the stuff. So you're learning like anatomy and physiology and biochemistry. And then you're learning kind of the basic sciences and how things are supposed to work. And then the second year, you're learning like the pathology, like the things that when things don't work. And so in your first year, you learn how the heart and the lungs and the brain and your gut and all these organs work normally. And then the second year, you learn about the pathology of each of those organ systems, and then diagnoses and treatment options. And then in your third year of medical school it's called your clerkship year. And so in your third year of medical school, it's a lot of fun. You're finally out of the classroom. You're finally able to go into the hospital. And what you do is you march your way through all the different core medical rotations. And so you do what we call clerkships. And you do clerkships in the main areas of medicine. So Currently, our third year medical students do 8 weeks of medicine, internal medicine, 8 weeks of surgery, 4 weeks of emergency medicine, 6 weeks of pediatrics, 6 weeks of family medicine, 6 weeks of psychiatry, and 6 weeks of OB-GYN. And that makes up your whole year. And so when you're doing a clerkship, that's the entirety of what you're focusing on for that time period. So when I have students who are doing psychiatry, they are doing psychiatry for 6 weeks. And that's what they do in the clinics or in the hospitals from whatever their hours are. They keep the hours that the doctors and the residents keep. So if they are in clinic with me, they show up and work from 8 to 5 in clinic, and then they go home and they study psychiatry. So they're reading their books and they're practicing their questions. And then they take an exam at the end of that clerkship that's subject specific. And so they just march their way doing that. So if they're doing surgery, they might be getting up at crazy hours, going to the hospital, doing the surgeries, following the shadowing in surgeries and observing, following their patients after surgery. And then they go home and they study surgery. And then at the end of that rotation, they take a surgery exam. And so that's what third year looks like. And then fourth year, they have a little bit more, they have tons more flexibility because they need to make their decision about what type of medicine they want to practice after they graduate. So they have elective time that they can go in and do. So it's a very rigorous process. It's just a lot of book learning, a lot of commitment to your education. But again, if you've made that commitment and you enjoy what you're doing, it's absolutely worth it. Psychology is that track again would be like after undergrad, you can make a decision to do like a master's program and then continue on with your PhD in psychology. You have to take the GRE to get into graduate school. And then depending on the program, it can determine the number of years of study. So a master's program is typically like 2 years. So about a 2-year program after undergrad to get your master's in whatever you're pursuing. So psychology is your undergraduate degree, but it can open the door to different graduate degrees that you can pursue. So we will see students who graduate with a psychology degree go on to maybe do like a master's in counseling, and that would be like a 2-year program, or perhaps go on and get their PsyD or their PhD in psychology. And then that can be, maybe a total of 6 years. And so either track is gonna take a while, but again, if you, if that's just your passion and your interest, then it's definitely worth that pursuit.
I have a question. I don't remember the term you used, but you said like in the third year, you kind of like make your rounds where 6 weeks you do one thing and then another thing. Was there one where you just said, absolutely no, I'm not going to do it?
There were a couple. But what was great was I enjoyed every rotation that I had. Like I thought every rotation was just so interesting. And I think I admire observing people who love what they're doing and people who have committed, the surgeons that are in the hospital from 4 a.m. to 8 p.m. all the time are there because they love doing that. And just to witness that and see that dedication was truly amazing to me. So I enjoyed my surgery time, but never once did I think I wanted to be a surgeon. Like I was like, thank you, this was so great, I'll see you later. But it's also really awesome, right? Like it's super cool. Like I'm never going to be a surgeon. That's not my calling. But I got to do, at the time it was 3 months. I did 3 months of surgery and I got like an insider's view and I got to learn all this stuff. And that's pretty cool. And so, it definitely enhanced my training. So it was, a lot of times it can come down to more like lifestyle or just personal interests. So those surgeons, again, they love surgery and they want to be in the OR all the time. and I don't think that was my calling, but boy, do I admire it. And boy, did I learn a whole lot from it. So yeah, there you kind of cross some things off your list. You're like, nope, not going to do that. But that doesn't mean that you didn't learn a lot or value the training. Every rotation I did contributed to me being a better psychiatrist. And that might not make sense if you're like, well, how does surgery make you a better psychiatrist? But every clerkship I did, every rotation I did, I'm learning how to talk to patients, how to communicate with patients and families. I'm learning so much about the amazing things medicine can offer, as well as the limitations that medicine has. And you can't really do that until you slug through all the different specialties and really see, what's going to fit you the best. So emergency medicine, some people love I want the adrenaline rush. I want to be in the ER and see I'm like, no, you take your adrenaline and put it over there. I'll just be over here being calm. And so there were things that I knew were not for me, but not because I didn't like it or value it, just personality wise, it wasn't going to line up with me. I'm not a adrenaline junkie at all.
But their passion is still so inspiring, just like watching them, like you said.
Yeah, absolutely. I mean, just someone who is an expert in their field is awesome to see, like, even if you hate that field. But there was not anything that I hated. There were just things that I liked more. But, for example, some students can't wait to learn how to do sutures and sew up stitches and sew up a body. And, some kid comes in with this cut and they're like, oh, I'll do it. And I'm like, you go right ahead. I don't want to stick a needle through skin and tie a knot. And so, everyone finds their path. Some people can't imagine doing psychiatry all day, every day. And I just think that's the greatest job in the world. And so you just kind of find what works for you.
Yeah, for sure. We had another question in the chat. It was, what are the different types of counselors? She said, I know about LPC and people who specialize in specific mood disorders, but what else is there?
Yeah, that's a great question. There's like a lot of different ways to be able to be a counselor. And so someone can be a counselor, counseling their, and, I say patients, they say clients, taking care of people, they will say that those are their clients. So there's a lot of different ways to provide counseling to your clients. So there, LPC is a licensed professional counselor. There's social work. You can be a licensed clinical social work degree that is providing counseling. So counseling is like the modality. Counseling is the tool in which you are helping your client, but the degree can be very different. So you can have a master's in counseling. You can have like I said, you can have a master's in social work. And then what happens to be able to get your training to be a counselor, you have to do a certain number of hours in counseling and like supervised counseling hours. And so if you are a social work degree and you want to get your master's in social work, but you want to do clinical social work, then you have to do a certain number, and it can be a lot. I mean, it's like hundreds of hours of supervised counseling time, and then you take a licensing exam. So you can provide counseling to patients via licensed professional counselor, LMSW, which is a master's of social work, LCSW, licensed clinical social work, master's degree in psychology, PhD in psychology. So there's a bunch of different degrees that all can, in one way or the other, provide clinical care and counseling. And then within counseling, I can just say there's a ton of different therapies, right? So you can do marital and family therapy. You can be a child therapist. You can do play therapy. You can do trauma-focused therapy. You can do cognitive behavioral therapy. You can do exposure therapy. So someone who has OCD and is all freaked out with germs can go to a therapist who specializes in exposure therapy and work on that fear. You can do parent-child interactional therapy. So there's like just tons of different modalities. So within psychology, then you can, again, kind of hone in on where your passion is and what group of patients you enjoy working with the most.
right, so our next question was, how do you typically begin a session with a new client? What is the process of helping a child open up to you?
So you are starting that interaction from the moment you call them in from the waiting room. And sometimes even before, because if you're walking through the waiting room or you're talking to your staff up front, they're watching and they're paying attention. But you're walking them, you're getting their vital signs and seeing how much they weigh and what their blood pressure is. And all the time you're just starting to talk with them like, hey, I like your shoes. They light up. That's so cool. What grade are you in? What's your favorite thing about school? Oh, I hate math too. And you're just kind of breaking the ice and you're just getting them comfortable with talking to you. And then when you get into the room, everyone kind of has a thing that they say. But I'll usually say, Johnny, what brings you in today? First of all, who are you here with? Oh, that's my mom. Okay, well, what brings you and your mom in today? Do you know why you're here? And they always go, say, well, what did your mom tell you about today? Did she just throw you in the car and bring you here? Or did she tell you anything about it? And then I'll kind of pull apart, what they understand about what the reason for coming in. And so if I can get them to say it, I will try and get them to say it. And it'll be something like, I'm here because I'm in trouble at school all the time. And then I'll say, oh, okay, well, tell me more about that. And then we start having that conversation. If I can't get anything out of them, they're just shrugging their shoulders. I'll say, well, I heard your mom say that you're getting in trouble at school a lot. What do you think of that? And then we can kind of start talking. But it's all about building that relationship with them and building that trust to where they start to feel comfortable to share with you. Sometimes, well, all the time for teenagers, that usually means kicking the parent out of the room because I am not going to get this great relationship if the parent is sitting right there listening to everything that they're going to say. And so with teenagers, I'll often say like, hey, mom, let me hear your concerns and I'll ask you some background questions and then I'm going to kick you out and then I'll talk with your kid for a little bit and then I'll bring you back in and we'll talk some things over and then I can 100% guaranteed get more information from a teenager if the parent's out of the room. And that's only fair to the teenager. I mean, like, come on. So, but that's just kind of in a nutshell.
Another question was, how regular are your work hours as a psychiatrist?
So my work hours as a psychiatrist are very regular. My clinic is from 8 to 5, Monday through Friday. I usually show up by 7:30, sometimes a little earlier, and then I usually work until about 5:30 to get all my work done, and that's pretty reliable hours. So in terms of predictability, in the outpatient setting, you're pretty there's a rhythm, because clinic is only open from this time to this time. So that doesn't mean if clinic ends at 5, you're not walking out the door at 5. There's stuff to do to wrap up. But so yeah, my typical hours during the week would be like 7:30 to 5:30. If you are in the hospital setting, that can change depending on your shift and all of that. I take call as a doctor, you kind of cover each other so everyone can have weekends off, and that's called call. And so every so often you're the doctor that's on call on the weekend, and so you work Saturday and Sunday. And depending on what specialty you're in, that can be like really, really busy or it can be manageable. But that's kind of share the love, right? That's if I take call one weekend, it means that someone else is doing that the next weekend so that I can have it off. And that's kind of how medicine works.
And then the next question was, how different is child psychiatry to adult psychiatry besides the parents?
It's crazy different. So in adult psychiatry, you have one patient and it's the person that's in front of you. And in child psychiatry, you might have like 3 or 4, depending on who all comes to the appointment. So the child is your identified patient, but you are going to talk to the child. You're going to talk to the parent. You might be talking to the step parent. Grandma might have come. The neighbor might have driven. I mean, it can get involved. And so the big difference with adult psychiatry versus child psychiatry is just kind of you're working with a family. In child psychiatry, you're working with a family. And so, so absolutely, I am working with that parent. And so, in an adult psychiatry, in a you hope to be able to have someone in their life that is their support that you can talk to and partner with, but that doesn't always happen. And so the story you get is from the person that's right in front of you. And some people really like that. Some people like, I have one patient that I have to talk to sort things out. And other people like, I've got this whole room full of opinions and let me sort things out. But that's the big difference is child psychiatry, also geriatric psychiatry is really like family. It's a lot of family work, and adult psychiatry is more the one-on-one.
Another question, how do you go about creating a plan of care for a child when their parents are so involved?
Well, the parents need to be involved, right? I want them to be involved. And so we're all working together to build that plan of care. You know, from my standpoint, I'm going to be talking about a lot of things. I'm going to be talking about whether or not I think medication is indicated, what I think medicine can accomplish and what I think medicine can't accomplish, what kind of parenting stuff might need to be addressed to help the child do the best they can, what kind of counseling things need to happen to help them do the best they can. So, you know, you cannot treat a child without treating and taking care of the family. And so, and that's also by law, right? Like I can't prescribe medicine without the parents consenting. And so, so I want the parents involved. Now, where that question probably is coming from is like with teenagers, like, you know, how do you build that rapport and trust with a teenager when the teenager is just going to want to, you know, make sure you're not going to rat them out to their parents. And so that again, that's a balancing act, and it's a trust, and it's talking about confidentiality and what can be shared and what can't be shared, and being honest about that up front. And then by being honest about limits of confidentiality from the beginning, that can help me do the job I need to do to keep the kids safe, but also try and protect their information that that is important to them for me not to blab to everybody.
I have one last question for myself. Do you have like a favorite age group? Like, do you, I don't know, like teenagers or like little
I love all the children. I really, I love my job. I see kids as young as 3 and as old as however old you are when you graduate UTSA, and that can be 22, that can be 54. And so, you know, I just really think I have the best job in the world because I get to see all the ages. I think that I really get a kick out of taking care of the littles, you know, the 5 through 12-year-olds. You know, I can fist bump them, and I can, you know, it's just fun. And so I get a kick out of that. I really value the work I do with adolescents because I mean, my adolescent patients will tell me more stuff than my own adolescent kids will. And so I really value that trust that they show in me. I really love working with kids with developmental disabilities. They just hold a special place in my heart. So we have kids with autism or Down syndrome. And that's, you know, that probably pulls on my heartstrings the most.
Well, we do have one last question, but we are at 6 o'clock, so it's up to you if you want to answer it. But it is, where do you think the line is between suggesting medicine and suggesting regular therapy?
I think it's the line is different for every scenario. And I think that it's what's going to be in the best interest of the patient. And that usually comes down to functional impairment. But even functional impairment might not be best addressed with medication. And so it really, really is just going to depend on the information I have before me. And sometimes it's a combination of both. By the time someone comes to see psychiatry, they often have already tried these other modalities of treatment. And so by the time they come to me, they've even it's been recommended from their counselor or their primary care doctor or their family member. So by default, I'm getting a lot of people where the recommendation is for me to start medications because they've already tried some of these other things, or because of the severity or the length of time that they've been suffering. That's just going to be the intervention that I think will help them the fastest. But I can't operate in a bubble. And so I can't say, take this medicine and everything will be fine, because that, makes no sense to anybody. And so, there's always other things to offer. It's never just about medication. But there are times when medication is going to be at the top of the list. And there's other times where medication may not be on the list at all. And so again, that's the fun part of my job.
Well, thank you so much for asking all of our questions. It was really, really informative. And I know I'm not the only one that feels inspired. I think you have an amazing job. It seems really, really rewarding. But yeah, thank you so much for being here.
Yeah, absolutely. And again, I just love UTSA, and I support everything that, anything we can do to support our students getting their degree is absolutely worth it. So if there's anything we can do to help support you on your journey towards your degree, let us know. But I it's just a privilege to get to talk to y'all tonight. I appreciate it.
Yeah, thank you for taking time out for us.
Absolutely. Y'all take care.
You too. Thank you so much. And then to our members, don't forget to sign out before you leave the meeting so you can get a general meeting credit.
And I'll stay behind just a little bit longer if anybody has any questions. So yeah, and if you want to talk privately, then I can make a breakout room and talk to you privately as well.
I want to be a psychiatrist now.
Me
Yeah, I wanna do that
too.
I just feel like it's so long.
Yeah. No, I don't think I could be the kind of person for that, but it's really cool, it seems like.
The medical school thing that she said about the rotations, it kind of sounds cool, but I don't know. It does seem like it's so time consuming and hard.
She made it seem like they try and make it interesting, but I know I'm the kind of person where it's like, if it's not psychology and if it's like a hard math or like science, I cannot find the time or attention to study for it. Like I just won't. And I know myself that I just won't. So for the sake of my GPA, I never took any like really hard science classes or anything like that, Kudos to everyone who wants to go to medical school, because
My sister's in the process right now. She applied to 20, I believe, because she graduated from U Chicago, and she's a nervous wreck because she hasn't gotten any responses yet, and she's just freaking out about that. So I feel bad for her, and I'm just like, I am not going to do that because I am not going to overstress myself.
that is stressful. Oh my gosh. I think I'm stressed out.
I'm scared
Yeah.
of masters, much less a doctorate.
Yeah, I'm in the process of like applying or like looking for grad schools and the master's programs, and I'm just so overwhelmed already. I haven't even started, and I'm just like, and especially with the money, it's so expensive.
The money. Mhm. No, yeah, me too.
Gosh, and I'm just like, Fern, like, I don't know what we're going to do because I don't think I'd be able to work like a full-time job while in school,
Yeah. So are you thinking of like going into grad school like straight after undergrad? Because that's what I was thinking of doing. But then once I started to like actually research, I was like, I don't think I need to work first and save up, and then I'll try to apply. But
Yeah, I think like I know myself, and I think if I wait, I won't go, and I want to go. So I'm hoping to start like next fall or the earliest. I know at Our Lady of the Lake, they have like 3 start times, and one of them is in May. So I'm thinking maybe that one, because I'm just looking at what best benefits me and my goals. So I'm
I think
thinking
I think that's even a statistic where it's like if you don't continue right after undergrad, like most people don't go back, but at the same time, a lot of people just rush into it and then they regret
Mhm.
they didn't take a gap year and then they just took their time and really decided. So it's like, which
Yeah.
see, I'm taking 6 months break, basically,
yeah,
the whole
that's a
semester.
good amount of time. Like, I don't know.
Yeah, my sister took a 2-year gap. So I thought that she wouldn't go back, but it looks like she is. The only thing is now she's basing like what school she goes to depending on her boyfriend, what school he gets into as well. The thing is that she's like way smarter than he is. And I'm just like, girl, do you
Yeah.
forget him? I just don't like him, honestly.
Oh.
But
Oh,
so stressful.
yeah, I have my GRE in a month and I'm like, why?
No, they waived
take-
them for this application process. Did you know that for UTSA, Our Lady of the Lake? Yeah, they waived them, and I'm like, I'm not even going to stress about it because I hate exams. I don't want to take the GRE.
I wonder how many people like got in because they didn't have to take the GRE.
Right. Yeah, no, all the programs that I'm looking at right now, or all the schools, they're all requiring it for, they explicitly say like fall 2022, you need your GRE. And I'm like,
Yeah.
what?
Mm.
Yeah, they-
Alexis, have you started preparing for it? Like, have you studied for it?
She
I like
said,
I like very in like a high stress moment, I like bought an expensive GRE prep because I was like, if I don't spend money on it, I'm not gonna sit down and actually do it. So now that I've like wasted resources on it, I'm like, okay, I have to study.
You've committed.
Yeah,
why
I'm
don't
committed.
you look into the class that they offer at UTSA? Because I was going to take it, but I found out about it way too late and I didn't have time to anymore. But it's like an actual class, but it's only 1 credit, but it preps you for that. My advisor
even-
told me about it.
Oh, well, I have to take it like in a month. So
Oh, well,
yeah.
yeah. Never mind. How much are you paying for it?
The actual test itself for the prep,
Yeah, for the actual exam.
I don't remember. I think it was like 1 something, maybe 2. I don't remember. I was like, I need to buy it, so I'm just gonna not
Yeah.
look. Just buy.
just take my money.
Yeah. Yeah.
I'm looking at
That's
the
a lot.
application fees as well. There's the applications fee for like grad school are, well, it depends because some are really pricey. I think some are like over, like way too much, and then there's some that are like pretty cheap.
Oh, really? Yeah, they're up there like $100,
Mhm.
25. I don't know.
Yeah.
I haven't really started looking yet.
Yeah, my sister said that for her med school applications, the like average for her is like 300. Yeah, but she's like applying for like a financial aid, so they're waiving them. But
Oh,
yeah, but I mean, she still has to pay like a percentage, but it's not like the 300. And I'm just like, dang, these like schools are making money just from applications. Like they don't even have to accept them. But that's crazy. And she applied to 20. But she
20?
like,
What?
yeah, she applied to 20 schools, but she's in this program. It's because she's a genius. Like in high school, she joined this program called Quest Bridge. And they basically gave her a full ride. And she's still working with that program to help her get into med schools. So that, if y'all have any high school or middle school siblings, tell them to join Questbridge or Emerge because those are really good programs.
Is it Quest?
I wish I knew about that. Wow.
Yeah, it's Questbridge. It's really hard to get into them though. She was always in the top 10%. In fact, she was always like top 5% valedictorian. She was a valedictorian. And
That's
so
crazy.
Yeah, she's a genius. And so for Emerge, it's a little easier to get into that one. But yeah, if y'all have any siblings like in middle school or high school, y'all should tell them to look into those programs because they start as soon as you're a freshman, or if you're already like a junior or whatever, they start prepping you right away for how to do the applications, what you need to do to get into the schools, and they still like work with you throughout your college experience so you can graduate well and then go into whatever further education you want. So
That's
they're
so
great programs.
cool.
I know. And like I didn't know about any of these programs. So yeah.
That's
Yeah,
so
me
cool.
neither.
Wait, what does your sister want to do in like the medical field?
Oh, she's studying to be a trauma surgeon.
Oh, that's so cool.
She's like really, really smart.
Dang.
Yeah,
She sounds really smart.
yeah, she is. But yeah, and my younger sister, she's 17 right now. She's smarter than my older sister. So I'm just like, what the heck? I feel like the dumb sibling.
You're not.
No.
And I have my little brother, so he's cute.
Aw.
But no, they're really, really
God.
everyone laughed. Does anybody have any questions for me? For Imelda or Bella?
Oh yeah, I just wanted to ask like a little more about like a volunteer coordinator position, just
Yeah.
what I'd be expected to do.
Yeah, so I know I told you a little bit like basic what they do, but to go into more detail, you'll be in charge. So I don't know if you've submitted any requests on Rowdy Link or to the officers. Basically, as a volunteer coordinator, you have to keep up with that and update the roster. We also have officer meetings like every 2 weeks, I think. It also depends like how busy we are, because sometimes we won't have officer meetings for 2 weeks, or I don't know. Officers, how often do we have meetings? I can't keep track.
I would say like every other week or like once a month or something.
Yeah.
I would say like every other week. I have it in here. Let me check.
Mhm. And then it also just depends like how busy like we are, but officers are required to attend those meetings. It depends on the president if they'll be like, okay, we'll have 2 separate meet times, or if you have to attend that one meeting. There's also like individual meetings that you have to do. So those individual meetings, it's typically like 3 per semester. So it's at the start or before the semester even starts. They kind of just meet with you one-on-one. So the president meets with you one-on-one just to talk about, okay, do you have any questions about your roles? How are you doing in terms of getting everything started before the semester starts? The one that's between like mid-semester is more of, how are you doing? How are you feeling? Are you okay? Like, how's everything going? What are you thinking about next semester? Are you wanting to possibly change positions? That kind of stuff. And then the one at the end of the semester, if you're continuing as an officer, it's more of, again, how are you doing? How did you think the semester went? What do you recommend should be done? That's one thing that we always take into consideration, like the officers' opinions. And we want to make sure that we're all like working together to plan out the best semester we can, especially since like every semester we're only like limited to certain amount of meetings and topics and events. So yeah, I think, well, I'm biased, but I think joining the officer team is amazing because you have all these resources and you can build friendships, and it's also really great for your resume and your CV. And you gain a lot of experience in leadership as well. So yeah, also if you do decide to apply, I'll send out documents. We do provide documents for incoming officers and for current officers that go into detail about your position, what your duties would be, so it can be easier for you to like manage everything and handle everything. Apart from that, Alexis is going to be one of the presidents next semester, and she was a vice president before, so she also would be able to assist you with anything that you need, really. And I'll be gone, so I'm graduating this semester, but Alexis is going to be a co-pres, and then Mariah is going to be VP, and then Mariana is here. She's going to be the social media marketeer. Oh, and then Logan's our PR. So yeah, you'll have a lot of resources available. So it can be, well, I don't know. It sometimes may be overwhelming as a new officer or just the application process, but it won't be because you have a lot of people to help you out throughout the process. So, you know.
What I will say is that, like, as president, because I have been volunteer coordinator, and there's going to be 2 volunteer coordinator positions open, that I'll be working like pretty closely with y'all and helping y'all, because both of you are going to be new and don't know what you're going to be doing. So I'll be like having probably a lot of meetings with y'all, or just showing you the ropes sort of thing. So there's really nothing to worry about. But I will say it's a little bit more time commitment than the other positions like PR or the fundraising chair. I think it's just a little bit more time commitment. So, but it's nothing too crazy. I mean, 5-10 hours a week maybe.
Yeah. The only so have you gone to any in-person volunteering? Well, if you have, basically you'll be like in charge of the group. So maybe Mariah might go, or Alexis might go, or Emily might go, one of the officers might go, but doesn't matter like the ranking, you'll always be in charge. Either you or the other volunteer coordinator will be in charge of that group, and you'll be in charge of checking the sign-up sheet, creating a group chat for the people that have signed up, arranging rides if needed, doing sign-ins at the actual volunteering. And we don't do sign-outs for volunteering. And then you'll be in charge of giving them instructions at the end of the volunteering, how to request credits. And then you'll be in charge of going on Write a Link and make sure that those requests are approved. It sounds like a lot, but it's like really like simple once you kind of get the gist of it. And sorry, my dogs are like, once you get the gist of it. And then, like I said, Alexis is going to be there to help you out. So Megan is one of our volunteer coordinators now. She's going to be secretary, so she'll still be here. So they'll both be able to help you out through that process as well. So if you would do want to apply, applications open on the 26th, and you can let me know if you're interested in any other position, like, you know, we can talk about those as well. Yeah, I plan on creating like a document and adding in the descriptions of every like position that's available and sending those out to the people that are interested. So I can do that for you as well, if that helps. Yeah.
Awesome. Thank you so much.
Of course.
Officer meeting time.
So I think I'm gonna head out because my dogs are like wanting to go out. So, all right. Bye guys.
Bye.
See y'all on Thursday. Bye-bye.
Bye.